Hello and welcome to Sasha Says. I'm Sasha Gardner and I'm so excited to have you here with me as I embark on this new chapter. In this podcast, I'm speaking to incredible people who will be sharing their stories and expertise, and I hope that will help inspire you and help you on your journey. Please also don't forget to press the follow button, like, comment, and share with your friends. It's a small thing for you, but a huge thing for us, and it really does help. So firstly, Mr. Sabbagh, I would like to say a really huge thank you for coming on the platform today. I know that the viewers and the listeners will really appreciate all of the information that you're going to give them. And with that being said, I would like to jump straight in. If you could kindly introduce yourself to the viewers and the listeners and explain briefly what you do, that would be wonderful.
Good morning, Sasha. Good morning, everyone. And thank you for inviting me. So my name is Mr. Sabbagh. I'm a plastic surgeon at the Royal Free Hospital in London. And I've been a consultant for nearly 20 years, offering ear reconstruction for Microtia patients, trauma patients, and burns patients, and any other ear abnormality. All my reconstruction is using autologous rib cartilage.
Could you explain what Microtia is and how you got into the field?
So Microtia literally means little ear. It's a Latin word, micro and otia. And it's an underdevelopment of the outer ear. And it happens in the first trimester in pregnancy. And there's different grades, so you can have just a tiny earlobe, or you can have a little bit more, but essentially it's an underdeveloped ear. But with it, you have the meatus is also underdeveloped. So sometimes it's not present or it's very tight. We call this atresia. So often microtia and atresia are go together. So you end up with an abnormality of the ear and an abnormality in hearing. So what got me into this, it started back in the 90s when I was training, and the only person who was doing this in the whole of the UK, who I'm sure you know very well, was David Galt.
Yes. He's retired now, by the way.
Yes, and I was a trainee under David Galt, and at the time, I think just seeing it for the first time, plastic surgery inspires us because it's a transformation, whether it's a breast reconstruction, whether it's a cleft lip and palate, and it's a change that makes us go into plastic surgery. But when you see an ear reconstruction, it's like the ultimate transformation. So it's challenging, it's a transformation, the creation, and the artistic part, and it's very unique. So it's a rare abnormality. So together, these are quite attractive things that inspired me to want to do this field.
How rare is Microtia? Is it one in how many thousand are affected with Microtia?
I mean, it's quoted as 1 in 6, but that's not a lot of cases in the UK, maybe 100 or less a year. But obviously, if you go to Asia, Japan, China, it's a little bit more common. It's a little bit more common. So it can vary between 1 in 4,000 to 1 in 10,000.
And I know you explained that there's the lack of the outer ear, but could you just briefly explain how that affects the hearing, please?
The hearing is affected because of conduction of the sound. So essentially, the sound has to pass through the external auditory meatus, then it has to pass through the middle ear to reach the cochlea in the brain. So the cochlea in the brain will be normal, but the sound cannot be transmitted normally because the meatus is tight. That in itself is not the only reason. The middle ear, the small bones in the middle ear that allow the sound conduction, also are abnormal. So there is a conduction hearing loss in Microtia.
So the purpose of today's episode is to obviously educate and inform the listeners. If, say, for example, there were parents listening with children of Microtia, or anyone for that matter with Microtia, and if they decide that they would like to perhaps look into going down the reconstructive route or rebuilding the ear using rib cartilage, what does that process from start to finish look like in your experience?
Put my phone on silent in case it rings, right?
That's okay.
So, I mean, obviously, to start backwards a little bit, the operation cannot be performed before the age of 9.
Before the age of 9, okay.
Yeah. And the main reason, there is not sufficient rib cartilage. The chest is too small. You can push it and go down to 7, but generally we wait till 9. So if you're asking me the process, often I will see the child much younger than that age. So let's say they come to me the age of 2 or 3 or 4. Then at that point, education is important and making sure they are seeing the right person for hearing. At that stage, hearing is the most important part in managing the microtia, supporting the parents, educating the parents. In my experience, the child is not concerned about the appearance of their little ear at a very young age. It starts after the age of 6 onwards, where they become a little bit more aware of the problem. And often at that age, they still don't want surgery. They don't want any treatment. And I think parents try and explain that to them if they're not aware of it. Show them the results, explain to them the safety of the operation, what can be expected. But importantly, making sure they are under the right ear, nose, and throat surgeon and the audiology department, so the hearing is managed appropriately. So it's all educational and hearing up to about the age of 7 or 8 when surgery is considered. And that applies to rib cartilage. We haven't talked about Medpor, but my area of expertise is rib cartilage.
So just specifically relating to the rib cartilage, so let's say you have a parent and they decide to come to see you because they're not sure about whether that they want the child to have surgery. Do you help them make that decision, or what happens?
No, I think it's a joint decision between myself, the parents, and the child. But the person who's most responsible for that decision has to be the child. Okay? Never, ever, ever force the idea of such major surgery. And when I say it's major, it is major, but it's not dangerous or risky surgery. It's big surgery on a child who's not ready. I think the results and the recovery and the psychological benefit are much better when the child wants the operation. So if a child comes to see me at the age of 9 and let's say he's unsure, I think I would like to think that I can put them at ease, explain to them that there's no rush for this operation. It can be done at any age. It's obviously better to do it when you're young than to do it when you're old because the cartilage is softer, but that young period or young window can go on till 14, 15. So it doesn't have to be at 9. I will show them results. I will show them what it's done, but I'll keep it very simple. I will not go into detail about, actually their main concern is pain. They don't really think much beyond that at that stage. So you put their mind at ease from that point, you show them the results. And I think if they're not ready, it's better to see me in a year's time. If they are sort of semi-ready or keen to make a decision, I can bring that forward to 6 months. But the consultation will be open till the child decides that they want to proceed or they prefer not to have surgery at all. Either way, they either go on a waiting list or we can discharge them. But the majority will proceed with surgery with the right time.
In terms of percentage, how many people would you say, children, decide not to go ahead with surgery?
I would say about 20% are not ready, so they're just inquiring, but the majority are keen to proceed by the time, because they've traveled, they've seen other ENT surgeons, they've been to different departments, so by the time they've reached the roll free, they have almost decided they want to proceed. They may not be old enough, often the chest is not quite big enough. If they're the age of 7 or 8, I tell them to wait a year or 2, but if they've come at that age, 9, 10 onwards, often they're ready to proceed. But if they come at the age of 6 or 5 or 4, then they just see me annually. They see me once a year. 10 to 20% of those patients, to answer his question specifically, who are ready for surgery from a technical point, may not be keen to proceed.
Okay.
But many of them change their mind as the years pass.
So day 1 of the surgery, what does that look like? How does that process happen?
Now, if you come to see me and you're keen to proceed, your parents are keen to proceed, then you go on the waiting list. But assuming that the surgical date comes along, you actually are admitted on the morning of surgery. So you don't need to come the night before. It's very routine for us, the operation. The nurses on the ward have a system that they follow. The anesthetist is a trained pediatric anesthetist, and who will see you in the morning. And it's quite smooth. You're admitted at 7, you're down into theatre by 8:30, 9. The surgery can then take about 7 hours. Now, not all that 7 hours is operating. I spent about 40 minutes drawing, marking, making sure the ear is in the right position, the access is correct, the angle is correct. So cleaning, infection prevention, all that could take 40 minutes to an hour. And the surgery has like 4 parts to it, all done at once, all done at the same time. The first part is to create a pocket, then you need to harvest the rib, then you need to carve the rib, then you need to put it all together. So that could take about 6 hours. After 6 hours, you return to recovery. You'll be given painkillers and you stay in recovery for 1 hour. And after that point, the parents will come down and they will escort with the nurse the child to the ward, and you will stay 3 nights. It used to be a lot longer. I think when you had it, it was a week that you stayed there. Yeah. But 3 nights we've seen is sufficient. Patients, we have improved the rib harvest technique. So the recovery from that is a lot quicker.
Okay.
And assuming there's no problems, there's no reason to stay on the ward just to observe the ear. So you can go home with an appropriate dressing, and then you can be seen a few days later. But 3 nights are sufficient.
And are there any complications? So this is what we call stage 1, isn't it?
This is the first stage, to make an ear. So you go down to theatre with no ear, you come back with an ear. But that ear is attached to the head, it's close to the head, it hasn't been separated. There's not enough skin in the first operation to cover that, to make you the ear and make you the back of the ear as well.
So just for the viewers, so basically imagine there's no ear here. What you're saying is that you make the shape of the ear from the rib cartilage, put it all together so it's the shape of an ear, and then you slot it onto the side, under the skin of the side of the head.
Yes, obviously it's not just simple slotting. There are is the earlobe that's already present that you have to manipulate and bring it to fit in with the other ear. And there is the abnormal cartilage that you have to remove. So there's a lot of work done before slotting the ear.
And then, so that's stage 1, that is 3 nights in hospital. And then what is the time gap between stage 1 and stage 2? How long does that process take?
I mean, the absolute minimum is 6 months.
Why is that?
Well, if you think about it, the ear is placed under the skin. Stage 2, you are cutting the outer edge of the ear. So you are actually cutting all the blood supply that you relied on in the first stage for that ear to live. Okay, because you literally cut all the vessels that are entering the ear from the scalp. So you're relying on new blood supply developing in 6 months from deep inside that will keep the ear alive if you were to make that incision. 6 months is the minimum. Often it's not 6 months. Often it's longer than 6 months. Remember, after the first stage, you do have an ear. And that ear, because it's a little bit thicker than the other ear, it looks quite normal, even from the front. There's no rush to the second stage. The second stage has its own complications and has its own recovery. And I often think it's no reason to rush it, because the longer you leave it, the better embedded and the blood supply the ear has. So if you were to wait a year, that's even better in my opinion. I don't think that, from my experience, the children are in a rush for the second stage.
With stage 1, the child goes home. And how long is the recovery for stage 1? So when can they go back to school?
I think they need about 3 weeks.
3 weeks.
It shouldn't be more than that. 3 weeks, making sure the cartilage is healed, there's no infection, they're mobile from their chest. So about 3 weeks.
And are there any complications?
I mean, every operation has potential complications. Now, if you talk about complications, there's the donor site complications from the rib. So if you go online, you can read a potential number of risks. But I think if it's done by expert hands, it's very, very safe. And in 20 years, we haven't had a single complication from rib harvest. Whether it's bleeding, infection, whether it's pneumothorax, air around the lungs, we are very, very careful. The main issues with the chest is some mild discomfort, mild pain that can persist for a few months. So that's the chest. With regard to the ear, I mean, the main complication, putting aside suboptimal cosmetic outcome, whether you call that complication or not, I'm not sure. But we have to also set, not everybody will have a brilliant looking ear. Everybody will have a good ear, but I'm not going to call that complication. The complications is mainly skin necrosis, which is some of the skin doesn't fully make in this operation. And we're talking about a tiny area, possibly 0.5 centimeter by 0.5 centimeter. So if you were to have that area anywhere on the body, that would heal within a week. But because there's cartilage underneath it, it just doesn't heal, and that could take longer and longer to heal. And sometimes you have to do secondary operation just to remove a bit of cartilage to allow it to heal. Now that, in my hands, is quite rare, and I would say it's less than 5%.
Okay.
Infection, major risk, but we again have a very, very low infection rate, probably less than 1%. As long as you address that problem very quickly, then it shouldn't cause a problem. But if you leave it, it can cause the cartilage to dissolve. So infection, skin necrosis, swelling can persist, mild discomfort can persist around the ear. And then we used to use wires.
I can't. Yes, I'm very aware of the wires.
Yes, to put the rib together.
Yes.
But very recently, in the past year, there's been a shift, a trend to go to sutures, to dissolvable sutures.
But
when
do
I
they
say
hold
dissolvable,
that cartilage in place? Because at least
I know. Well, we used to think they won't. But these stitches that we use last for 6 months. And I think one person in the world tried it. And he went on about it, and another one tried it, and this is how it worked. We all know each other. And in the last 6 months, I've moved towards sutures too. So we're sort of no longer using wires, or very few wires, in the ears. And that's based on some surgeons in the world having been using sutures for not having problems.
Basically, what you mean is that when you take the cartilage and you're taking pieces of rib cartilage and essentially making the shape of the ear, and you're saying that the old way of doing this would be to sew that cartilage together using the stainless steel wire, and now it's actually moved on to sutures instead.
When it was first ever done, it was stitches. It was not wire, but they were permanent stitches.
Okay.
They were permanent stitches. Then the wires came along. They were just...
Could you just move your camera, because we've lost the top of your head? There we go.
Sorry.
Perfect.
So back in 60s, 70s, 80s, a lot of surgeons used permanent stitches, and they can cause problems. But then the wires came along. They had finer needle, and they were easier to use, and we all got into the habit of using wires. There's no reason why you can't. Permanent stitches and wires will both do the same job. You just need something to fix the ribs together.
Yeah.
It's the idea of using dissolvable stitches, which has not been used in the past. We all thought if you use dissolvable stitches, then the framework might fall apart, it may not stay. Apparently that's not the case. After 6 months, it sort of molds together. So in my opinion, that's a big improvement, because you don't have the risk of wire extrusion in your case, or the risk of a stitch infection after a few years, because after 6 months to a year, there are no more sutures in that framework. So it's just pure rib cartilage. So that's a good thing.
So talking about the wire extrusion, what you mean is that sometimes with certain patients, the wire can unfortunately come through the ear.
Yeah, just
when
come
that happens,
to the surface.
It's quite simple. It's just a case of pulling it out.
Well, it can be simple. I think it should have been simple. It should be simple. Yeah.
Wasn't simple for me. I cried like a baby.
Yeah.
Anyway, that's okay. So, okay, moving on to stage 2. What does that look like?
Stage 2, I think it's always important to explain to people that stage 1, the transformation is amazing, from no ear to ear. And no one can deny the big change and the benefit. And stage 2, you're trying to create this gap using a skin graft. And skin grafts, as you all know from burns, they're just never going to be skin substitutes. They're always going to contract, or they're always never going to look 100% normal. So I think it's important to set the expectations appropriate for stage 2. The aim is separation. You're never going to have the back of the ear. We call it medically the sulcus.
Okay.
The sulcus at the back of the ear. That's never going to be normal skin. It's never going to be the right amount of projection. Okay, like the other ear. But the ear will be separated. Okay. And that will help you wearing glasses, and it will help you to maybe mobilize the ear. Now, there are things you can do to improve the projection. You can put more rib behind it, but that's a little bit more complicated. And often I explain both procedures, and patients choose to have just the skin graft. Because when you have the skin graft, I don't know if you probably had a bit of rib, because I think
I had rib cartilage at the back, because I remember when they harvested the rib cartilage, they left a small part,
a little bit to use. Yes,
yeah.
Yes, that's correct. Yeah. Look, that's a good technique, and we've used it many times. But the problem, I don't know in your case whether you have a lot of projection. Often that piece we leave behind is just not sufficient to support the framework, and you may end up to have to take more rib, which a lot of patients don't want. The skin graft gives mobility to the ear, okay, but the ear means it remains visibly close to the head, but from the front you can't tell because it's a thicker ear. So from the front, it's only from the back when you compare the two ears, the one which is being released will look closer, the gap will be less. Okay. Again, in my experience, patients don't mind that because from the front it looks normal. But if they want that projection visible from the back, we can discuss putting a piece of rib behind the ear.
So would you say that the second stage is less invasive than the first?
It's definitely less invasive. But there's more healing involved. Because the graft has to live. The skin graft is relying on a blood supply from the bed. So it's a little bit more wound healing involved in the second stage.
So I've done stage 1 in my ear now, and it's flat against my head. And so the second stage would mean you're essentially cutting behind the ear to
Cutting,
raise the ear
correct.
and taking some skin, which is usually taken, I believe, from the thigh.
No, the one from the thigh is what we call partial thickness,
Okay.
which means you leave dermis behind and the thigh will heal by itself, like we do in burns. I prefer to use full thickness skin, where you take it from an area and you close the defect. Because if you leave it, it will not heal. You've taken full thickness skin.
Which area would that be?
Well, it has to be either the groin, because there's a bit of loose skin. You need to have loose skin. Or sometimes from around the scar where I harvested the rib. I have found that long term, it does give a better result. Now, with all these operations, the second stage, you can have wonderful results with any technique, whether you use a split thickness graft, whether you use rib or no rib. And you have to look at the overall average of 100 cases to decide what technique I think I should use. So you may have had a split thickness graft, you may have had rib, but not everybody gets good results with one technique. So I think I did a study where I compared the different techniques, and I did find that if I was going to put rib behind the ear to allow it to project, then that rib has to have a good blood supply to cover it, just like the first stage. And in your case, it's called the fascia that was used, came from the mastoid area. The blood supply of that is not fantastic, but it does the job in many cases, and I've done hundreds and hundreds. But better blood supply would be from under the scalp with the blood vessel to
Oh,
turn that
wow.
around
I've never
behind the
heard
ear.
of that.
Yeah, it's called the temporoparietal fascial flap. It's what the Medpor surgeons use for their Medpor ears. But we wrap that behind the ear. Now that gives a much better blood supply to the back of the ear. The problem with that operation, it ends up being, instead of 3 hours, becoming 8-9 hours.
Oh.
By the time you harvest more rib, by the time you cut the scalp and you rotate the flap, yes, it does give a very good blood supply behind the ear. But a lot of children, it does mean shaving the hair. They don't want the hair shaved for that. And overall, my experience, very few prefer to go down that route of having a much bigger second stage operation. They just want the ear separated, and that's why the skin graft is a very, very safe technique. But if you were to put rib, you have to wrap that rib with something else, because you can't put the skin graft on the rib. So you wrap it with fascia, and in your case, and I'm sure I've done hundreds when I was with David Gold, we use the mastoid fascia.
Yeah.
There are a few potential problems with that, and when you see one, you decide maybe I shouldn't. All it takes is one case.
Yeah, of course.
You decide that it's probably not the best way. So it's not my preferred choice to use the mastoid fascia now, having done it for many, many times. So if somebody wants projection, somebody wants a piece of rib behind the ear, I prefer to use what's called the temporoparietal fascia, which is a much better vascularized fascia.
And in terms of any complications with the second stage, so when you're speaking about blood supply, does that mean that the skin graft could potentially not take and then fall off? Or
I mean, the skin graft falling off is not a problem. It's the back of the ear. It's not the front of the ear. You can always redo it. A bigger complication than that is, let's say you get an infection in the second stage and you end up losing the benefit you've gained in the first stage, because any infection is destructive to the cartilage. So I'm not saying that's common. It's very, very, very uncommon. But the Microtia group in Canada and Toronto have stopped doing second stages.
Really? Why?
Completely.
Because of infection?
I think that because they put so much effort into their first stage to create the framework. And I think they lost one, and they decided they would rather just give a little bit more projection in the first stage, there's no proper gap, but the ear stands out a little bit. Now, we don't do that. We are very, very, very careful of the second stage, but yes, there are complications of the second stage. And I think it's like everything in surgery. If you are very careful and if you're meticulous and you make sure sterility and blood supply, you minimize these complications.
It's just very difficult, isn't it? In the sense that if you are a child, you're having these surgeries done, they don't really think like adults, do they? So it's really down to the parents to be meticulous and make sure that it's clean and that the proper measures are put in place to avoid infection, because of the severity, in the sense that you go through stage 1, that whole process, and then if it's not taken care of in stage 2, it can ruin the whole thing.
Yeah, but I don't think it's down to the parents. I think it's down to the surgeon. I think we have to cover. So that's why the operation is, it's an incredibly sterile operation, and the amount of washing and cleaning that's done, and then the antibiotic ointments that's covered, and then the dressing stays on for a week, and everything is covered. So actually, we're trying to eliminate every source of infection.
How long on stage 2? How long is the hospital stay on stage 2?
1 night.
How long is the recovery?
Obviously, there's a dressing for a week.
Yeah, and that's to prevent infection.
Because any graft, any skin graft, for it to live, it has to adhere to the bed. Now, obviously, if you leave the ear loose, that graft could fall off. So by packing the back of the ear with nice cotton wool and antibiotics, ointment, and holding the ear with a bandage, you're allowing that graft, not just the infection, but the graft to actually gain its blood supply.
And
because the graft has to live from the back of the ear.
It's such a process, and it's so fascinating.
It's all about blood supply. The whole of
all
ear
about blood supply,
reconstruction.
guys.
It's all about blood supply. Ear reconstruction is all about blood supply.
And I feel like I'm bombarding you with questions here, but I am doing it on behalf of the listeners, and I know you guys will find it really informative. So in terms of recovery process on stage 2, how many, is that 3 weeks? Is that 2 weeks?
Well, it's more a healing process than pure recovery, because you do need 2 weeks for that graft to be sort of adhered well and the ear can be handled. There's not much physically to recover from the surgery, but you need 2 weeks for healing, wound healing. Remember, the healing in the first stage is just skin to skin being stitched. But the healing in the second stage is a skin graft living, surviving by what we call diffusion. I don't know if you know that term from biology, where the nutrients and the oxygen come from the bed, and then it's got to develop its blood supply. That takes time. So for it to adhere, it takes about 10 days.
Okay. And so let's say stage 1 is complete, stage 2 is complete, and now everything's recovered. And then obviously there's stages in between that, isn't there, where patients will come back to you to have the bandage taken off. And that's one part I would love to dive into a bit more, because in terms of expectations, because a lot of people, they will come to you and they will say, okay, I have Microtia, or my child has Microtia, and I would love you to, I would love to have reconstructive surgery. And you'll obviously talk them through the process step by step, which you're kindly doing here today. And they decide to do it. At the end of it, they then have that after stage 2, the bandage removed, and there's an expectation, isn't there, in terms of what it should look like?
Surely the appearance is at stage 1, is it? So they expect once a bandage is removed at stage 2, it's there. It's the same ear that you had at stage 1. So the first seeing it do you mean the bandage removal after stage 1 or after stage 2?
Well, either or, really, because you've gone from essentially nothing there at all, or maybe a small earlobe, to then having
so that's after stage 1.
What's the reaction when they see it?
I mean, often I show a photograph to the family, because I take pictures in theatre, and it's a very, very, very joyful reaction, and the children, it's best for them to see the photo, because after 3 or 4 days, swelling creeps in, and when they first take the dressing down, it is swollen. it will not look as good as theatre.
In
And that will
theatre,
just,
it looks incredible.
it looks incredible. So then it takes another 3-4 weeks for that swelling to really come down. But they're delighted. I think straight away they can see the shape of the ear. I mean, you don't need an intricate, detailed ear. For them just to see the contour of the outer ear and not to actually see they have no ear. And they're often very, very, very happy. Very happy.
And then fast forward, let's say 6 months after stage 2, how long do they keep coming back to see you until eventually you discharge them?
I mean, in theory, once the graft has fully taken and everything is, the blood supply is all healed, after 6 months they can be discharged. In theory, I like to keep an eye on the ears because obviously the more follow up, the more educational it is for me too, to see any problems, any issues. Because sometimes with the second stage, the ear can creep back close to the head. That's one thing we see a lot. And we do have a putty, a mold, silicon mold, that you can fit in at the back of the ear. So that's a good time to do it, around 3-4 months. So I could see them again regarding that if they're finding the ear is creeping towards the head. But they will see me as needed. I mean, I rarely discharge anybody before a year. But often, if they don't live too far, I'll see them every year for a few years just to make sure there's no problem. But usually, I need a year follow-up for the second stage.
And
just to make sure that there's no contraction, there's no scar problems, they're managing the ear appropriately and they're cleaning it appropriately. You will find with any ear surgery, whether it is ear reconstruction or even sometimes prominent ears, I've found the natural oiliness of the skin is not as good, and you get buildup of keratin that you do need to clean from around the ear. So I teach them how to do that as well.
what would you suggest using to clean it because of where it is and how sensitive the ears can be?
I mean, I think saline is absolutely fine.
Salt water,
saline. You
guys.
get warm water, saline, the contact lens solution, some alcohol wipes, just
Yeah.
anything to remove that sort of that yellow buildup of keratin. Some people don't mind it. I don't think it's a big deal. Because
And
once it's all healed, the cleaning is not about infection prevention anymore.
yeah,
The cleaning is more about appearance, making it look its best.
from people that I've spoken with, even after the first stage, sometimes they're disappointed because they are in their mind expecting to have an ear which looks identical. Let's say you were born with one ear and they want to have reconstructive surgery. They have an expectation that it will be identical, and it is never the case. From your experience, what do you think about that?
Well, I hope my patients, I'm educating them enough that it'll never, ever, ever be like your other ear. Never, from many angles.
One thing Dr. Galt said to me is, we're trying to trick people into thinking you've got two ears.
That's a great way of doing it. I mean, we're trying to make sure the fact that you have no ear is not an attention issue other people when they see you. Because very few people see the two ears at the same time when they talk to you or when they engage with you. So if we reconstruct an ear that looks like an ear and it looks like a normal ear, yes, it's different. Why is it different? Well, it's thicker. It's not. It can't be as thin because if we make it as thin, it will just collapse. It doesn't bend. It doesn't move as much. It's not as intricate, but it's got the shape from, the outer shape is the same. It's got all the bits, got all the trachea, it's got the antihelix. Honestly, think very few people will be able to tell. But apart from the ear, it's really important to get the position of the ear, because it doesn't matter how good the ear is. If the ear is not in the right position, if it's a little bit too low, it's not a very good thing for the patient. So getting the position and the angle are essential to tricking people. I think that's a great line.
Yeah,
I mean,
I never
it's a
forgot that, and
it's a great line.
it stuck with me actually. Now I know
I
a lot
mean,
of
one thing we have now, probably, I'm not sure if when you did, we have the images and the computer. So we show them. We show patients. I mean, there's plenty online and plenty on my website, and people can see what a reconstructed ear looks like.
yeah.
It's not the same. It's a nice ear. I think you can't dispute it's a nice ear. But no, it will not be like your other ear. And I think that's a really important part of the consultation.
Yeah, because otherwise it's someone having unrealistic expectations and something unless I mean I know that you obviously do this with your patients, but if it's not reiterated right at the beginning, then it's a huge case of disappointment at the end.
But my
Bad
experience is people who are
expectations.
disappointed, they have every right to be. Generally, their result is not as good.
So
And
what I found is lots of people who do decide to go ahead with the reconstructive surgery, they still feel conscious at the end, even though they've got a fantastic looking ear. They still in their head, it becomes subconscious that they still feel they don't look the same as everyone else, which is a separate hurdle to jump over.
yeah, that is a psychological
Yeah,
issue, but it's very much linked to how good the result is, isn't it?
of course. It's all down to how good the surgeon is.
But
Well,
even, I think all it takes is a minor complication to affect the result. So I think if you get the position of the ear right as a priority,
yeah.
the position and the size, then if you're dealing with an ear that doesn't look perfect, that it's a better situation to be in. It's when you don't have the position correct. It's not easy to manage expectations. I don't know what the best way is. I mean, we don't have access to a child psychologist. They're all free. That would be ideal. That would be absolutely ideal. A plastic surgical psychologist who sees the patients and talks to them. But the best way around it is to try and show them as many pictures as possible and just do a nice ear. I think if you cannot, I'm not talking about myself, if you cannot make a nice ear, I don't think it has to be the same as the other ear. It's got to be a nice ear. It's got to be a nice ear. That's the point.
So in terms of hearing, is there anything that can be done to, because I know that when you're born with microtia, you're born with no hole at all. So when you have the ear reconstructed, it obviously looks like an ear, here, but there's no hole at all. So from your experience, is there anything that can be done?
Well, I don't manage hearing. So
Yeah.
the ear, nose and throat surgeons will manage the hearing. Bone anchored hearing aid is well established, and it definitely improves the hearing. I don't think it reaches normal levels, but it definitely improves the hearing.
When you do your reconstructive surgery on microtia patients, do they have the bone anchored hearing aid before, or do they usually have it after the microtia reconstructive surgery?
All the bilaterals will have one.
Okay. Bilateral guys, both ears missing.
Yeah, you can't, otherwise you'll have no hearing.
Yeah.
The unilateral, the one-sided microtia, it's really a choice. It's a choice, and it's what the ENT surgeon, his own thinking process, whether he believes all unilateral microsias should have hearing augmentation or not. The current philosophy is to provide a soft band. So you have the hearing aid, but not with a surgery. And you trial it out. If you are getting that benefit, you feel, to your social life, to your interaction, then you would proceed with the bone anchored hearing aid. The issue is when to apply the trial soft band. Should you apply it at birth? Because if you apply it at birth, you are committing the parents to making sure that it stays on, but you're getting the child used to that bidirectional hearing. So it's a slightly controversial issue. I think the ENT and audiologist, they all feel very different about it.
That's really
And
interesting.
that's why I don't get too involved.
Yeah.
We have our own audiology and ENT team. They're all free. So if a child comes to see us and who is not under an ENT surgeon, then I would ask them to see the one we work with. But often they're being treated locally at their department. And depending on the ENT surgeon, their policies, what the parents and the child want, sometimes they come to me with a hearing aid. And sometimes they come to me with a decision, I'm talking about the unilaterals, the one-sided, of not to have any hearing aid. Because they manage absolutely fine with one ear, but they will do better with two ears. That's well established. So I don't get too involved, but what I do advise is if you are having a bone anchored before your Microtia, check with a plastic surgeon or myself how far it is. It should be around 7 centimeters from where the hole is.
To make sure around here, wouldn't it?
Yes, to make sure the skin for the ear reconstruction remains viable.
Yeah.
For the surgery.
A few more questions for you. We touched on.
But just one more thing to say, because you did say they have no hole, no meatus.
Yes.
Yeah, we don't create a meatus in surgery. I get asked that quite a bit. If you have got a nice ear, a nice tragus and antitragus, these components.
So that's really that part here?
Yeah, if you manage to create that surgically, that hides the fact you've got no hole. And it actually looks very natural. But creating a hole, first, the hole will not be in the right position because the bone, and second, will be too wide and it may discharge and it looks quite ugly. So often we do not go down that line of creating a hole.
Can they make a hole? I know you don't do it, but have you ever heard of anywhere that can do that? Is that a possibility?
Of course, making a hole is a possibility. You just drill in the bone and you put skin grafts and you make a hole, yes. But that doesn't in itself improve the hearing, because the middle ear, the conduction will remain abnormal. So if your question is, can you make a hole and improve hearing at the same time? In selected patients, very few patients, if you do a CT scan and you assess the bone and you assess the structure, again, that's not my territory. That's a specialist ear, nose and throat surgeon. I'm not aware of anyone in the UK who offers that type of surgery where it's to the middle ear and to improve the hearing. And it's controversial. When I've been to meetings and listened to results, it's controversial. But I think where in Los Angeles, where they do the Medpor, in selected group of patients, they create a meatus. I don't know their results about the hearing improvements. But I don't think they create a meatus in everybody. Not in everyone.
I mean, the Medpor route is relatively new, and I really don't know much about it.
See, Medpor is an artificial substance, so there's no rib harvest.
So it's less invasive, essentially.
100% less invasive, yes. But you can't put the Medpor under the skin because it does have a higher risk of infection and extrusion.
Because
so all the Medpor cases, no, it's not about rejection, it's about extrusion and infection. It's not rejected. So all Medpor cases have to be covered by this flap that I was talking about.
Okay.
So all Medpor cases, in the old days, they used to make a cut through the scalp and raise the flap to cover the Medpor. Now they're raising the flap from the same part of the ear by a small camera. But you have to raise a big flap and wrap it over the Medpor.
Okay.
Because that gives a much stronger blood supply than the skin. Then you have to put skin grafts. That's how Medpor is done.
So Medpor is only one stage?
It's only one stage, but your ear, first, it's not biological, and second, it's not covered by skin. It's covered by a flap and a skin graft, which are slightly different texture to normal skin. The different sensation, different texture. I can't really comment. I mean, I believe rib is better when rib is done well.
Of course.
And when the donor site is handled very, very, very well. Because what you don't want is make a nice ear and give a horrible chest. But what I don't know is the long-term results of Med.
Do you know how long Medpor's been around for?
It's been around for a long time. It's being used. It's actually used medically in many other areas. It's used as a cheek implant, chin implant, used in the nose. It's used in many parts. It's well established. There's no rejection with Med. It's well tolerated in the body. But the problem is if it gets exposed or infected. If cartilage gets exposed, it will heal. It's biological. If Medpor gets exposed, often you may have to remove the Medpor or do something technically. And I don't know. I've been to John Reinach in Los Angeles, who popularized Medpor in the last 20 years. And yes, he does amazing surgery, and I think they look incredible. But I don't know long term how that Medpor ear compares to the cartilage ear. So the advantage of the cartilage ear is that it's covered by your normal skin, and that's a nice texture to have. It's biological. If it gets infected or gets extruded, then we can manage it. It can heal. Okay. The advantage of Medpor is you can do it at a much younger age, and you don't need to harvest the rib. But then you have a non-biological ear, which is risk of extrusion, risk of infection, and you don't have your normal skin. Without a long-term asking the patients who've had Medpor and who've had rib and finding out what they think, it's very difficult for us to be very honest about comparing. I don't want to go and say Medpor is bad, and the Medpor people shouldn't say rib is bad, but we need our patients to tell us what they think. So somebody should go out there and investigate Medpor patients and rib patients. But the problem with Medpor and rib, you can have a horrible Medpor result because it's done by the wrong surgeon. You can have a horrible rib result done by the wrong surgeon. Go to the right surgeon. You choose to have Medpor for your own reasons. That's good. If you choose to have rib, that's good.
You touched on something really which stuck in my mind there, and that is that it's always really hard, isn't it, making these decisions, because this platform is not about promoting surgery at all. This platform is to educate and give everyone the information that they that we can give in terms of a collective, and that is the options that are available to someone who suffers from microtia or with any hearing impediments. And so typically if you're a parent with a child with microtia, or you're someone with microtia, you would go online, you would look at what you could do, and you would then maybe have a consultation with the surgeon. But the question is, like you said, which surgeon should I go with? Because that will impact the outcome, and it's about it's being put at ease and knowing that you're going with an experienced surgeon. So I think that, this episode, if you do decide to go down the surgery route, just gives you all of the insights and all of the information to sort of help you make that decision. But I think you touched on something really important, which is find the right surgeon, because, do your due diligence, look at results from other patients, because I think it's really important.
Just go to a center that does this all the time.
Yeah.
I think, unfortunately, a new surgeon, there's going to be some sort of learning curve, but everyone has to learn at some point. I can't do this forever. There will be someone else coming along. But as long as that learning is done in the institution, under guidance, then we can keep those good results. I think that's important.
Fun question. How many ears would you estimate that you have reconstructed rather, in your time in doing this?
Remember, probably half of my reconstruction are not Microtia. Human bites. People are surprised. Human bites, burns, probably about more than 1,000, I would say.
Amazing. And I think it's time to wrap this up, because I'm very conscious of your time. If and when the listeners would like to get in touch with you, what would be the best platform and the best way of reaching out to you?
Probably if they want a simple answer, then they can send me a message on Instagram, which is ear.surgeon. It's not my preference to go into detail on Instagram, because that's very time consuming. But at least I can guide people where to go. I think in the end, this operation is performed in the NHS, and you have to be referred to the center.
Do you work with the NHS, and then do you work privately as well?
I do work privately, but I do very few Microtia privately, very few, because it's very expensive surgery, it's very time consuming surgery, and it's available on the NHS. I do get some international patients coming to see me for private reconstruction for Microtia, but a lot of my private works tend to be more other issues to do with ears, like large ears or prominent ears or that sort of thing. not Microtia surgery.
So if you do want to get in touch with Mr. Sabbagh, then you can contact him on all the I'll put all the details below. And I just want to wrap this up and say a huge thank you to you, because I really want to just be clear about this, that this episode is if you decide to go down the reconstructive route and what that looks like for you. We're not here to promote surgery. It really is a personal choice, and there are lots of people out there as well that do decide not to do it and live a life and be happy. So it's really a question of what works for you. But I really hope that this conversation has added colour and reassured you that if you do decide to go down that route, what that looks like and the benefits, and reassure you that it's a positive thing with a positive outcome. Is there anything you would like to add?
We've covered so many things. I think I would say that try and be gradual with collecting your information. Build up information slowly. Don't rush to any decision making. The child will not get bullied at a very young age. That's my experience. If people are very frightened, so if your child is 2 or 3 or 4, it's rarely an issue until they reach sort of a little bit older. So that's one important point.
Well, thank you so much again, really, just for your expertise, your time, and I know you're highly experienced. So I'm just really grateful that you came onto this platform to join in the mission to educate and help other people and just make it easier, because I feel like these decisions are quite difficult as a parent or even as an adult to make. And hopefully, both of us have helped you on your journey with Microtia or any hearing impediment or whatever it is, making that journey a little easier. So on that note, I'd love to say thank you so much. And
You're welcome.
And we will speak soon, I'm sure.
All right. Thank you.